Bene, a questo punto possiamo aprire la discussione, sia per il professor Gotusso che il dottor Armignacco. Il tempo, diciamo, sarebbe scaduto, per cui se qualcuno però vuole intervenire, ecco, abbiamo già una domanda. Bene.
Professor Gutuzzo, first of all, thank you for your very excellent speech. My question is, you have introduced two types of acute renal failure in cholera, oliguric and non-oliguric. My question is, how can be explained a non-oliguric acute renal failure in front of a so heavy degradation? And the second, what is the most frequent in the epidemics of cholera? Thank you.
When you have a cholera, one of the problems is the patient is coming in different stages. Usually when you start, you reduce your volume of urine, and the moment you provide intravenous, sometimes we use 2 liters in 1 hour, or 3 liters, because the patient have 1 liter in 15 minutes. That is, we need to provide the kidney still is working. And the moment you can provide that, you immediately can provide very aggressive treatment. In that way, we've proven this is an acute renal failure, but it's reversible because you provide quickly treatment. For us, in adults, you need to provide quickly treatment without any lab. That is, you can make density. If you are in very poor zone, you have not electrolyte, you can use density, because the density is the kind of function you lose when you have a renal failure. That is, it's very easy to prove quickly this. Then if the patient you provide treatment still have diarrhea, but then have oliguric, we start to thinking very quickly to provide dialysis. Our hospital have very famous unit doing dialysis. Even they create one small equipment to have a dialysis very quickly, especially the old people. Right now, we know the people who don't respond and have oliguric function, that is the worst. When you start to have urine, even you have a renal failure, you can provide a standard treatment with the level of oral rehydration, and these kind of patients have very good prognosis. The people who have a good volume of urine, even they don't need dialysis, and they recover in the next 2 or 3 days. The advantage from the dialysis is you can reduce the mortality in the people who have acute renal failure with low volume of the urine, especially people who have more than 55 years and they have in shock, etc. That is the moment we use dialysis.
Sono altre domande per il dottor Gotusso? Posso io chiedere una cosa, Edoardo? Riguardo, fermo restando che le cornerstone della terapia è la reidratazione, però per quanto riguarda la terapia antibiotica, qual è per voi nella vostra area il farmaco di prima linea, considerando i problemi delle resistenze?
Right now, you know, tetracycline is a drug of choice when they're sensitive. However, the new strain, for instance, in Haiti is resistant. And right now, a good drug is azithromycin. It's funny because azithromycin is a good compound from typhoid fever. You have a typhoid fever from India, and they have a quinolone resistant, almost 60% are resistant to quinolones. You can provide azithromycin from 10 days. Right now, one of the treatment could be azithromycin. The second topic is you can use quinolones also. However, remember, in Asia, the people are using nalidixic acid as the marker. And when you have nalidixic acid resistant, probably 20% of your strain is also resistant to quinolones. The advantage of a ciprofloxacin, not the other, the ciprofloxacin have a secretion 10% in the bowel mucosa. In that way, Cipro is a good drug. Also have 10% of the Cipro when you use intravenous. 10% is secrete in the vial. That is the gallbladder have 10%, and the bowel have a secretion from 20%. In that way, the concentration is very high, and probably quinolone still is a good drug, even in one single doses.
Professor Gatti.
No resistance strains have been seen outside India up to date, isn't it?
Yes, there are some strains. The strain from Asia, who is in Haiti, is partially resistant to tetracycline.
In Southeast
because
Asia.
the strains came from Nepal.
From Nepal.
Nepal,
Yeah.
they have one epidemia, and the soldier who came, they have this.
But I have another question also considering the inputs about raw fish. Ceviche, which is the traditional preparation in Peru, was indicted as responsible of the further spread of cholera. But I imagine that is not a problem of the fish, but once more a problem of the water. In the 90s, we had a small epidemic of cholera in Bari, and the 80s. In the 70s in Naples, but the small epidemic in Bari was attributed to the very young squids. But the squids are cephalopods. It's very improbable that they can have inside a significant amount of cholera bacilli. Probably also in this case, the water, the contaminated water in which the squids are put before eating is the real responsible of this phenomenon.
You know, when you eat raw fish, you can have anisakis, and this is very important because in Spain they have these small, they call boquerones. They eat almost raw, and they have a lot of anisakis, and they make the extension to put in the refrigerator from less than 30 centigrades below, and then disappear. There are not cases in the last 5 years from this disease. And in Latin America, especially in Costa Rica and Ecuador and part of Mexico, they acquire nastostoma, very similar when you eat in Thailand, this kind of fish, raw fish. In Peru, it's funny because we eat ceviche 2 times a week, and we have not nastostoma. However, in the last 15 years, we have more relating, in my opinion, related to the Japanese style, because we are seeing nastostoma only in the high level of socioeconomical level, and the Japanese is very expensive. The style from sushi is very expensive, and that is raw fish. Ceviche is a marinade and almost cooked with lemon. In that way, probably for us, was not the sources from the cholera, was the water, not the fish. And the second is in the nastostoma, also probably related to the sushi and the Japanese style in our country.
What
not
about
the
Paragonimus westermanni now?
Paragonimus is only seen very rare when you eat in the river the crabs and you uncook it. Especially we are seeing in soldier, when you send to the jungle, and they say you need to survive, eat everything, snake, crabs, any. They acquire Paragonimus, but Paragonimus is not a common disease in our countries.
Ok, e un'ultima cosa, mi sembra giusto, Orlando. Beh, forse vale la pena di raccomandare ai nostri giovani qua di domandare molto bene quando vanno a mangiare pesce crudo se è stato abbattuto, secondo le buone regole.
Il messaggio iniziale è quello di evitare di mangiare pesce crudo, questo è il No, infatti non l'ho fatto. No, il secondo, naturalmente, ci sono delle norme igieniche in grado di poter evitare queste infestazioni, e soprattutto quello che viene detta, considerare che ci vuole l'abbattitore in modo tale che il pesce messo in condizioni particolari di temperatura intorno a -20, -30 per un periodo prolungato, poi non è più in grado muoiono i parassiti e quindi non è più in grado di trasmettere l'infestazione. Perché dico però la prima notizia è non mangiare il pesce crudo? Perché tutto questo è affidato spesso, è vero, a norme igieniche codificate, ma non sempre correttamente applicate e non sempre da tutti. Quindi voglio dire, dipende molto diciamo dal ristorante dove uno va, dal fornitore che uno utilizza, per sapere se poi questi alimenti sono stati trattati nella maniera che la legge prevede o prevederebbe.
Only one short comment. When you eat with one infection disease expert, it's very dangerous because they see the watercress have fasciola, this crab have this fish have this, and this really is a joke when we have this kind of lunch in between us. Our infection disease expertise is to try to provide you safe food, and it's very important how we learn about our disease and how we change our food to be more safe. For instance, frozen the fish is one of the good measures to reduce this, and again, this is absolutely important. One of the areas we are working right now, and it's part of our duty in infection disease and tropical medicine, is to reduce the parasitic disease, to reduce the bacteria, to reduce the virus. For instance, in some places, if you eat the mussels and cook it, you can have a cholera, you have a typhoid fever, you have hepatitis, enteric hepatitis. And it's very important to try to see this is one of the areas we start to be expert to try to reduce the infection disease with a good advisor from the restaurants and the cuisines in our country to try to improve and have a safe cuisine. Meantime, you can kill the bacteria, the parasitic with good wine from Italy.
Bene, ringraziamo. Se ci sono altre domande, se no andiamo al coffee break e dovremmo riprendere a mezzogiorno la sessione successiva.